Bismillahirrahmanirrahim. Assalamu alaikum, everyone. And thank you for taking the time out to come and listen to what I have to say. Just a little bit about myself. I have a degree in prosthodontics from King's College in London. I have a diplomate in implant dentistry from the Royal College of Surgeons in Edinburgh. And I'm an examiner in good standing with the Royal College of Surgeons still. I'm a fellow and diplomate with the ICOI. I am the ICOI ambassador in Pakistan, and I have an MFDS from Glasgow. And very recently, I was lucky enough to become the first diplomate from the American Board of Oral Implantology and became board certified by the American boards. That's my journey so far. I'm also the president of the Federation of Implant Dentistry Pakistan, which has been inactive for a few years now, but we've had some amazing events with speakers from the US, Germany, Venezuela, Palestine, Jordan, and some grand events that we've held over the years, and we've had some great support from Mr. Salman Manyar and all you, the rest of you as well. This is my practice in Karachi. We are in Clifton, and that's where the grind takes place every day. And I have a team which works very happily with me. This is, scarily enough, this is also a few years ago on my 41st birthday. And this is us working happily on Christmas Day. I was a great admirer of General Pervez Musharraf. He was a patient of mine also. I cried when he died. And I'd like to start with a little quote. If you and I exchange $1, we still have $1 each. But if we exchange a thought, we have two thoughts. And that really, I believe, is the essence of events such as today's, where we can come, collaborate, and share ideas. I will learn perhaps more from you today than how much you will learn from me. And so collaboration really is very important. I'm going to show you my first case. Cordless mic hai ya idhar hi rehna maine? Do we have a cordless mic? De dena yaar. Let's use it. So this is a case that I call the vampire sinus lift. Beautiful. And my surgeries are not as hardcore and fancy as Dr. Jawad just showed you, but we are working in the zone of implant dentistry, and this is a case that I really wanted to share because it's very interesting. This is a patient who was 45 years old when he presented to us, or 49 I think. This is about 8 years ago. He had bilateral painful swellings on both sides of the face. Piche awaaz sahi aa rahi hai? Because I can't hear myself. Awaaz sahi hai piche, Lisa? You can hear me, right? Okay, great. And so when we took a history, he said he's non-diabetic. He does say that he's a smoker. And he reported that, you know, sometimes he will have some marijuana, sometimes he'll have a drink. His wife said that it's not sometimes, it's more often than sometimes. So the first lesson really that I want to share with you today is when I see a patient like that, I don't take their word for it. I said, okay, let me just screen you. Okay? How many of us know about the ASA classification? The American Society of Anesthesiologists classification, right? So you know how paramount that is in categorizing your patients. So this patient was more of an ASA 3. Why? I will tell you why. Because when we did his HbA1c, even though he claimed to be non-diabetic, his HbA1c came out to be 10. Okay, now that just really outlines the importance of holistic care. So we referred him to a physician, and the physician then treated him with insulin pumps, etc. Gradually, over time, as you can see, his HbA1c started to come down, and when it came down in the zone, which is around 7, that's when we treated the patient, okay? Now, let's come to the actual procedure. I'm going to show you the upper right side only. The upper right side, we extracted the first and the second molar tooth. Okay, and what we did for him was an autologous tooth graft. How many of us have seen this technique before? An autologous tooth graft. Okay, so for me, back in 2017, this was something which was new and I was excited about it. So I had equipment from two different brands, two different manufacturers. One was this one, Cometa Bio, and the other one was the Vacuosonic. And I combined the two, I conditioned the graft. Okay, so this is the graft that we got. You can see it right here in a particulate form. And then I used the technique for harvesting concentrated growth factors, and I mixed the liquid phase of the growth factors with my particulate graft, and what I got was sticky autologous tooth bone graft. Okay, so I'm getting the advantages of sticky bone. How many of us have seen sticky bone before? How many of us have heard about it? Okay, so we all know the advantages it comes with. There's no graft migration. It is laced with growth factors from the patient's own body, so it has more regenerative, more healing potential. So I placed 2 implants in the saddle area where there were missing premolars, and then in the extraction sockets, the first and the second molar, I was going to do a socket graft, but I knew that would not be enough to get the volume of bone that I want to regenerate. So I did a lateral window sinus lift. So this is my lateral window sinus lift, and that's my graft. That's a barrier membrane, and 4 months post-op, you can see a good solid chunk of bone. Now my mentor with this technique is this Korean professor, Professor Son, and I said to him, I remember, that you know what, on the x-ray the bone looks, it looks patchy. It is opaque, but it's not the opaqueness that I'm used to see. And he said, don't worry about it, just go in. So I said, you know what, I'm going to make a video when I'm placing the implant so I can demonstrate the insertion torque of that implant, which was quite high. So my insertion torque was around 50. This was solid, viable bone. And then, how many of us have heard about implant stability quotient? How many of us have used an Austell unit or a similar unit to get the implant stability quotient? Okay, so the implant stability quotient, the ISQ, at this time was more than 60, which is perfectly acceptable in posterior maxilla, bear in mind. So this is how it was healing up, and 4 months later, once the implants had integrated, I called the patient back in and I did digital impressions. And at this time, this is back in 2017, I had just acquired my first wireless scanner by 3Shape. We were quite excited about it, and we got CAD-CAM abutments made, and these were done in a lab in Anaheim. True abutment was very new at the time, and now, as doctor would know from California, that true abutment is a giant. The CEO is a friend of mine, Dr. John Kim, is a good friend of mine. So these CAD-CAM abutments were used to restore those implants, and here's the zirconium crowns. Here's a 3-year post-op panoramic of the same patient. Here's a 3-year post-op cone beam CT images for the same patient. And now, it's really interesting. Anyone from Korea over here? No? Good, excellent. So I tried to contact the manufacturer for the Vacuosonic, and I said, okay, you know what, I'm going to take an exam, and I'm showing this case in my American board exam. They might question me, what is the composition of these reagents? And they say it's a company secret, we can't tell you. So then I spoke to Dr. Son, and Dr. Son gave me the reagents and their composition, okay? So, well, and the composition of dentine graft is very similar to bone protein. So dentine and bone have similar proteins in them, and these are just some references from the literature which can justify the use of this novel graft material. This is an 8-year post-op panoramic for the same patient. Here's the CT images, solid bone. And 8 years later, I called the patient for a review. I removed the crowns. I said, okay, you know what? Let me just take some Ostel values now. This is a new Ostel beacon unit. And the Ostel values, you will see, are in the high 80s. So 8 years later, the ISQ, implant stability quotient, is more than the gold standard. Anything more than 70 is an implant stable enough to be immediately loaded. And these implants were stable and had solid stability quotient after all these years. Okay. So we combined all these techniques together in the one case, and I thought it would be nice to showcase this case. Here's some references for those of you who like to have some literature evidence. And I spent these thousands of dollars to present this case at a conference in Spain to win a third prize of $500. But we don't do it for the money, we all know that. We do it for the passion that we have. Now, that brings us to the challenge of the resorbed sinus. How many of us have read about the MISH classification for resorbed posterior maxilla? Okay, so you have SA1, which is more than 6 millimeters of residual bone height below the maxillary sinus floor. And then you have the SA4, which is less than 4 millimeters, which is less than 3 millimeters of residual bone height below that sinus floor. Okay, and the approach that you use, the surgical plan that you make, will rely heavily on your residual bone volume, right? Okay, so how many of us have seen the crestal approach sinus lift? How many of us have seen sinus lifts? How many of us have performed sinus lifts? How many of us have done lateral window sinus lifts? How many of us routinely do crestal approach sinus lifts? We all know crestal approach is perhaps your heart is pumping less in your mouth and more where it should be when you're doing crestal approaches. A lateral approach is considered to be more technique sensitive, more invasive, yes? So let's talk a little bit about both. Here's a paper, very interesting paper, where even though literature suggests that an SA1 or at the most an SA2 is a candidate for a crestal approach osteotome mediated sinus lift, but in this paper they claim that even with severely resorbed maxilla, where the patient would be an SA4, you can place implants with crestal approach sinus lift. Okay, so that's workable. Now this is a video from a lecture that I was sitting in a long time ago. This was in Germany, and they showed an arthroscope in a cadaver demonstrating the actual procedure of a crestal approach sinus lift. We all know this by now, that the main determinant is where if you are able to infracture the sinus floor, lift it up, making sure that the sinus floor membrane, the Schneiderian membrane, does not tear. Okay? So let's see a case that I did. This is a long, long time ago when we were doing simple analog cases. And this is a panoramic where I measured the bone. It was about 5 millimeters. So this would be something like an SA2. And I make my osteotomy, not a very polite way of doing a sinus lift, and introducing a graft material, and you can clearly see the implant and a nice dome-shaped graft material contained under that Schneiderian membrane. And this is how the case was restored. Okay? Now, with lateral window approaches, where you have severe, how many of us would do a crestal approach on this? We can't. How many of us would say, okay, this is a candidate for a lateral approach sinus lift? It absolutely is. What class of MISH classification would this be? It's an SA4, where you have less than 3 millimeters of residual bone height under the sinus floor. And with sinus augmentation, especially if it's a lateral approach augmentation, there's a question, should I do it? Can I do it? Am I trained enough to do it? Do I qualify? Should I refer this to someone like Dr. Jawad, who's a surgeon, perhaps who's got a stronger claim to this domain than the rest of us? And more importantly, if I refer this, is my patient going to come back to me, or will he just become assimilated, acquired by the referred practice? In our culture, perhaps that's a concern that everyone has. And we all know with the lateral approach sinus lift, what are the basic parameters, basic principles? These are textbook images. You make a lateral window. This is using a tungsten carbide surgical burr, making sure that you don't perforate the underlying Schneiderian membrane, and using a blunt instrument, carefully you detach the membrane from the underlying periosteum, introduce your graft material in the space that you've created, yes, and then you place a barrier membrane and you close it. Now, this is a technique which is prone to complications, intraoperative, postoperative. It's a technique which is prone to membrane perforation being the most common complication. How many of us have perforated sinus membranes? I would raise both my hands. Yes? And how many of us, what do we do about it? Well, so this is where, this is a small tear, this is a large tear with a big hematoma accompanied. Again, a couple of small tears. And in small tears, many times, if you are cautious, you can proceed and finish the procedure. Yes? So, the procedure by itself, however, is highly successful. Some basic principles. Accurate outlining of the window. Make sure the window is large. The larger the window, the easier it is to manipulate the underlying membrane with less negative pressure. Always keep your instrument in contact with the underlying bone so you have more control. Detach the proximal part of the membrane first. This was an interesting principle that I learned. Now, if you imagine, although now we have these nice fancy SMD screens, if this was a simple projector white screen, and imagine the white screen being stitched to the back wall, and if I have to lift the screen from the base up, if I lift the screen from the base up with those stitches in place on both sides, what will happen? The stitches will tear. However, if I snip the stitches first, and then I lift the membrane from the base up, it's going to be smoother. Yes, so similarly, if you detach the proximal part of the membrane first, and then you start lifting the membrane up superiorly, it'll be less traumatic, less chances of membrane perforation. And of course, you have to know your anatomy. The membrane can be as thin as less than half a millimeter, and the bone overlying that membrane can be as thick as more than 2 millimeters. Okay? Posterior superior alveolar artery and its anastomosis with the infraorbital artery. How many of us have seen this bleeding during a window prep? We are not maxillofacial surgeons. Yes, we see more bleeding and we start to think what's going on. I've been showered with this. The anastomosis, when it bleeds like crazy. Okay, now, so the overlying bone can be as thick as this. Now, I'm going to put a question to you guys. In smokers, would we expect this underlying membrane to be thicker or thinner? How many of us say thick? Everyone has to vote. Use your right to vote. Thick, raise your hands. How many of us say thin? Raise your hands. No one, right? And that's our problem. We always vote for the wrong party. So, in smokers, the pseudostratified ciliated columnar epithelium of the Schneiderian membrane goes through metaplasia and turns into simple squamous epithelium, which is thinner. So in smokers, the membrane is thinner. And you can look up the literature on that, okay? This is just some references for that. And of course, post-op instructions. We all know that the maxillary sinus drains where? Where does it drain? In the brain? Where does... I'm going to put a question to you because, you know, we're not here for you guys to just sit through this, get your certificate and go home. Talk to me. Where does the maxillary sinus drain? This is basic first year anatomy. Wow. So who says it drains in the infraorbital region? Raise your hands. You're scared to vote now. Who says it drains in the mouth? Who says it drains in the nose? Well, we have 2 votes. Anyway, if we do this, we'll be here all day. We won't finish this. Yeah, so it drains in the middle meatus of the nose, all right? So patients, we always give post-op instructions, detailed written post-op instructions, okay? So patient screening is very important. And I'm going to now advocate for a textbook which is newer, which is more contemporary. And we all used to use Carl Misch as the Bible. It still is. But this is a fantastic book. I recently went through this and it has some amazing information. Okay, I have included some information from this. And when screening the patient, it says your screening steps have to be the first step, preventive diagnostic. Make sure you screen that sinus. How many of us have seen a chronic, massive oroantral communication which requires an obturator? How many of us have seen that? Dr. Jawad may have done that following resections of tumors and all of that. But how many of us have seen an iatrogenic, surgeon-induced, botched up lateral window leading to an obturator and a massive communication? I've seen that a couple of times. And it all starts with the flaw, with the fault in screening the patient, okay? And step 2 would be preventive therapeutic, where if you have identified an existing disease, get it treated. Involve your ENT colleague, get it treated. How many of us know what a FESS procedure is? FESS. What is a FESS procedure? Are we all dentists here? Are we all graduated? Any students here? Okay, well, you can be forgiven. What's a functional endoscopic sinus surgery? Okay, involve your ENT colleagues. And step 3 would be diagnostic therapeutic. Oh, you know what? I see a swelling. You know what? The patient is saying, I have bleeding from my nose. You know what? The patient is saying, when I drink, the water comes out from my nose. You know what? The patient is saying, I have blurred vision. You know what? The patient is saying, I have massive swelling and I fainted. I've been vomiting. Yeah? So let's look at this a little bit. Okay, CBCTs are very reliable, but we all did our sinus lifts with panoramic and PA X-rays, which literature says have a 73% reliability. How many of us know what the osteometrial complex is? OMC. You're probably thinking the guy is here to teach anatomy or what? Why is he here? But it's very important. What is the osteometrial complex? It is a common channel where several sinuses meet with the middle meatus of the nose. And this osteometrial complex has to be patent. It has to be open, ventilated. And that's where screening comes in. We have CT scans available to us now. Get the right images. Identify the osteometrial complex. There it is. Identify it. Learn to identify it. If you can't, that's fine. Speak to a colleague. Collaborate. Exchange thoughts. Yes? And if this sinus is somehow blocked, if it is blocked, don't go in there. Something is wrong. There could be polyps, there could be cysts, which may not heal. Yes? So that's what a patent osteometrial complex will look like. I'm going to show you a case that I did. I'll show you one of my first mistakes. Okay? This is a first molar. Yes, the root canal was done by yours truly, and it failed. And I said, okay, no problem, it's failed. Now the patient, by the way, was also an uncontrolled diabetic. I said, no problem, it's failed. I'm just going to remove this. It's time to do a lateral window sinus graft. I'll remove this. and I'll do a graft simultaneously. This, remember, a case is back in 2011 or 2010, I think. So you can all see that the palatal socket is draining pus, okay? I said, no problem, I've learned all of this. I raised a flap, thick bone, I make my window, and I started reflecting that membrane. You can very well see a big tear in that membrane. Of all the pictures I've taken in my entire life, I am the most proud of this picture. Because when you tear a membrane, your heart's pumping in your mouth, and the last thing on your mind is taking a picture, okay? So I took this picture, and I placed a collagen barrier membrane. I stopped doing further reflection on that membrane, on the Schneiderian membrane, placed a barrier membrane, introduced whatever graft material I could, placed another barrier membrane on the window, sutured this up, went home and started praying. Okay? And I know, looking back, Steve Jobs, the Apple guy, used to say, you can always connect the dots if you look backwards. And if I connect the dots, I still remember what happened. When I was trying to lift the base of the membrane up, the texture of the membrane felt different. You know why it felt different? There was a granuloma which was extending beyond the sinus floor. Yeah? Anyway, so this did heal uneventfully. I did manage to place an implant in this grafted sinus, and at the time of placement, the implant had an ISQ of, it was in the 70s, and then this was restored, and the patients had a few more implants since then. Okay, so it's very important to have sound knowledge of that sinus function and that sinus anatomy. Okay, so just an example, the picture on your left is from a textbook. The picture on your right is what I saw in my clinic. That's a picture that I took. So this patient actually came in claiming that I've had a bone graft after extraction of my first molar. And he said, you know, when I take a drink, it's coming out from my nose, and you can see that. Okay, so we should all know, at least with these basics, identify the condition, and it would be great if you learned how to treat them. This is still not that hard to close. Yeah, but this was a communication, it was a fistula. And it's oroantral communication is a fairly common complication following maxillary posterior extractions, okay? And you can have delayed complications. What is this? Any thoughts on what this is? Orbital cellulitis, okay? An orbital cellulitis is a complication which can happen when a sinus graft gets infected. It can travel. It can also lead to cavernous sinus thrombosis, okay? So be mindful of these. All right, and the optic nerve, if it's compressed due to the cellulitis, can cause blindness very quickly. Okay, so I think I've scared you enough about this. Let me tell you how this is done, all right? Here's another complication, a delayed complication. How many of us have seen this? Implants floating about in the sinus. Yeah, so this patient, the clinician tried to do a lateral window sinus graft with simultaneous implant placement, which perhaps wasn't stable enough. The case wasn't screened properly or was not performed properly, and that's where the implant ended up. There's another case. The patient said, I went through a full mouth specialist. Do we agree with this? No, we don't. That's terrible. Okay, so I've retrieved, in my career, I've retrieved some of these implants floating about in the sinus, but it comes at a cost, because you really have to go through that membrane, and you really don't know if that membrane is going to regenerate or not. Yeah. Okay, so I think the message has been driven home, yeah? Now let's look at this case, which we saw earlier, an SA4, severely resorbed. So I raise a flap, using just a simple diamond burr, I make a window, and I saw this in a lecture, Dr. Arun Garg from Miami. He said, he explained it very beautifully. He said, you know what, keep drilling in the bone with your surgical burr until you keep seeing bone color, and when you start seeing non-bone color, start slowing down, because that's now you're close to the membrane. So you can actually see the membrane is now showing through the window that I've created. Okay, and now cleaning this up, further removing those tiny little islands of the bone, I expose the membrane, and then using this sinus kit, I detach the proximal part of the membrane first, and then I lift the membrane from the base up, introduce my graft material, my barrier membrane here. This is long ago. This case is 2010 or something, when I was still using silk sutures. But this is immediate post-op. That's the comparison from pre-op to immediate post-op, okay? And then an implant was placed. I was using polished collar implants also back then. And somehow we had a consensus on giving this as a cleansable restoration, because the mesiodistal distance was so big, even though it was only one missing tooth, we wanted to avoid any cantilever forces. This patient also had a cross bite, so we maintained that, and we kept a cleansable contact there, which is debatable. But this case lasted a long time. I presented this at a contest in Prague with entries from all over the world. I got a third prize for this as well. And this on your left is the same case 16 years later. Okay, this was in 2009 when we did the case. Now, with bounded saddles, that changes things a little bit, because the mesiodistal area you have is too small. Again, this is an SA4, less than 4 millimeter residual height. And I'm using my diamond burr, and I don't have much space because I don't want to go and hit the root of that tooth distally when I'm doing my window. And this is my lateral window, sinus graft, same steps. And this is in 2013, immediate post-op x-ray. This is the same patient restored with an implant, 8 years post-op. And this is the same patient 12 years post-op. Okay, so it's a stable result long term. Here is another case. This patient, again an SA4, and I made my window, and one technique you can use is to ask the patient to breathe in and out through the nose. If you see that membrane moving, then you can breathe a sigh of relief that the membrane does not have a tear in it. Okay. And this was the graft material I used. This was an alloplast. I don't use alloplasts anymore. That's a debate for another day. And in this particular case, I reinforced the membrane with a collagen membrane before placing my graft. You can do that also. And then I did an implant simultaneously at the same time, because I felt that the buccolingual dimension of the bone was sound enough to stabilize the implant simultaneously along with the sinus graft. Okay, this is the same case with good bone fill 5 years post-op. I don't have more long-term follow-up on this. This patient passed away later, not because of the sinus lift, but she's passed away now. Okay, and sticky bone is a technique that we've also now started using since many years, 9-10 years at least, for lateral window sinus grafts. Here's a case. The lower implants were not done by myself. I don't agree with the way they were done. So the patient came to me and he was having trouble eating, and you can see obviously why. We started with the left side first. Okay, so just some steps of harvesting growth factors in liquid form and in the form of a fibrin block. Yes. And again, now performing my procedure, detaching the proximal part of the membrane first. This is my sticky bone. This is a combination of allograft and alloplast. Okay, and 4 implants were placed simultaneously. This is the right side of the same patient. Okay. And in this case, anteriorly I did an osteotome sinus lift, posteriorly I did a lateral window sinus lift. This is how the whole case was restored. You can see the sinus lift on the right and on the left. And of course the lower implants were failing, so we did a full mouth for this guy. Now, the risks and limitations of doing these procedures in the conventional way. Well, from a crestal approach, it's a blind procedure. You can't really control the force, can you? Because and it's not very polite. You're just, hammering away or maybe tapping away with your osteotome. It's uncontrolled. Okay? And one of the complications, although it's not reported very commonly, is benign paroxysmal positional vertigo. These patients can come back and complain of that. And this actually happens because there's tiny little stones in the cochlear canal which get displaced, and they can cause the patient to feel vertigo, yeah? All right. And the risks and limitations of the conventional way of doing lateral window is, of course, you can perforate the membrane. It's time consuming. It's not user friendly. And you can't do what is called a replaceable bony window. Difficult to do that. Okay, I'll show you how we do that now. Now let's look at this case. So I got a sinus kit which was gifted to me by a friend of mine. Okay, and when I got the kit, I was excited like a little boy. This is my nephew on the day that he learned how to stand up, okay? See how he's playing around? So I was playing around like a little kid. I was excited. So let's look at this case. This case, the implants, the case was referred to me. The other implants are not done by myself. And this patient, she had implants on the upper left side as well, which had failed. Okay, so this is more like an SF4 case again. And now using the kit, which has these lateral reamers with stoppers on them, and these stoppers come at varying depths from 0.5 to 1 to 1.5 to 2.5, extending up to 3.5 millimeters. And as you can see, this patient actually had a lot of thick bone overlying that sinus membrane. And once I had made my osteotomy, I was able to retrieve the bony window. And now you can see that membrane very clearly. Okay. So I detached the membrane, introduced my graft material, and then I replaced the bony window. This is the replaceable bony window technique, and the bony window is believed to be osteoinductive. And then I placed my collagen barrier membrane, covered that up with a PRP membrane, and it took me less than 10 minutes to do this window. The whole procedure with that big thick bone, it ended in less than half an hour. Okay? So 4 months post-op, the same patient, you can see big, thick, chunky bone, pre-op, 4 months post-op. Here's the comparison. Okay, now I can go and confidently place my implants. And when I did the flap to place implants, I was curious, so I took the flap a little deeper to see how that bony window had taken. It had taken quite nicely. And this is a video of the implants being placed, and you can actually see that the insertion torque on these implants is quite high. It's approaching 60 newtons. It's very, very dense, solid bone. So 2 implants were placed in this grafted sinus, quick surgery, and these 2 implants were then replaced. Okay? So that's the pre-op, post-op following sinus grafts, and then this is the implants and their restoration in the grafted sinus. Yeah, so here's another case where on the right side it's an SA4, and I expose the lateral wall of the sinus using the same kit. This is the series of the stoppers I have from 0.5 to 3, lateral reamers, and again making my window. Now in this particular case, the overlying bone was very thin. and the underlying membrane was also very thin. Okay, so you can see here the bony window being very gently retrieved, making sure the membrane is not damaged. There you see sound membrane. And now I go about reflecting the membrane and introducing my graft material. Now the bony window is replaced. There you go. And that's the graft visible right there. And we lost this patient after COVID. I never got a chance to go back in and do an implant for her. I'm quite bummed about it. Here's another case. This patient, again, the referred patient, the other implants are not done by myself. So on the upper right side, he had a failed bridge, and we did a lateral window for this patient. So you can see here, once you are at the desired depth, and if you gently just tap this little island of bone, you'll see it moving. So that means it's been detached from the adjacent bone. And now you can very gently just cleave that off from the underlying membrane. There you go. Okay. And this is now the detachment of the proximal part of the membrane first, lifting the membrane up. All right. Introducing my graft material. There you go. Oh, okay. Yeah. And then the bony window is being replaced. There you go. That's the closure. 2 implants were placed anteriorly, and you can see the graft concentrated in the posterior region. And 2 more implants 4 months later were placed in the grafted sinus, and this is how the case was restored. Okay. Now, crestal approach using these kits, it also simplifies that. Just to show you a couple of quick cases before my time runs out. And this is, again, crestal stoppers, which is used in crestal reamers. There you go. And we look at a case in the patient in the upper left, where it's more of an SA1 or SA2. She does have some bone. So using the crestal stoppers, I drill, make my osteotomy, get close to that sinus floor. And then once you're close to the sinus floor, you have this instrument, like a dome-shaped instrument, which can very gently just detach the membrane with some initial detachment. Yes. And you can see the membrane is still intact in this picture. There you go. And then we introduce the aqua tip, and we perform what is called aqua lifting. Okay, this was also an interesting concept where through the hydraulic pressure of the normal saline, you can lift the membrane atraumatically. And the concept from the manufacturer's training video is this. So with repeated suction and pressure and suction and pressure, you can detach the membrane gradually, making space for your graft, okay? So that's what we did, and then we introduced the graft material, and then the implant was placed with high insertion torque. These are the Austell values at the time of implant placement, very high values. Remember, an Austell value, ISQ value of more than 70, you can even immediate load the implant. I don't do that. And 6 months later, these 2 implants were restored, and this is the CT images of the same implants. Okay, so again, another case where I became a little more courageous. This is a case that I have been restoring. The other implants are also done by myself. And the upper left side, I extracted the first and the second molar. And then I became a little more adventurous, and I made an osteotomy through the interradicular bone in the upper left first molar. And I exposed that membrane. You can see the membrane right there. It's sound. Yes. Then I did crestal approach sinus lift with the aqua tip using the aqua lifting concept, and I placed my implant immediately with very high insertion torque, And this is the second implant in the second molar socket. I always use these prosthetic guide pins to tell me where I am, so my implants are parallel. These are the two implants placed immediately, and of course the sockets were also grafted. And this is the ISQ value at the time of implant placement, and then there was a socket graft, barrier membrane with collagen, with a dual layer membrane technique, the second membrane being CGF, PRP membrane. And then we did a periosteal release incision to get primary closure, okay? Now, with periosteal release incisions, the literature is sparse, and when I gave my Royal College exam back in 2013, I presented some cases with this incision, and I found only one editorial in Journal of Oral Implantology, and these are the guidelines for it. With periosteal release incision, this is how it healed up beautifully. What can you see wrong with this? Dr. Saab, what do you see wrong with this healing? You know what's wrong with a periosteal release incision when you sort of locate the flap more coronally? You lose attached tissue. You lose that attached tissue on the buccal vestibule, and you need that keratinized attached tissue if you want stable long-term bone levels around the implant. So what is then done is when you come back and you expose these implants, when you make an incision, the incision is located more palatally. Yeah? And you relocate that mucosa from the palate to the buccal surface. Okay? And these two implants were very stable. This is now the ISQ values at the time of implant loading. And here's the implants restored. Okay? I am going to stop here because I think I've run out of my time, and I will now skip to the end. That's my take-home message. Careful patient selection, proper screening, good surgical execution, okay? And these techniques which we have now, they do make the process easier for you. However, I would strongly recommend getting trained with conventional techniques first, okay? Now, simple techniques when applied with discipline and care can give predictable long-term outcomes. Remember, when I started my small talk that I've been boring you with, the topic was predictable results in unpredictable times, okay? I'm going to share a life lesson with you. This is, we come from a very strong Army background, 3 generations. I was a cadet in the Army Medical College myself. And you know, we have this is G.I. Joe. Sergeant Slaughter says, we all go home or nobody goes home. And I saw a real life demonstration of this. This is my father's farmhouse. My father was also in the Army, and now he is spending his days quietly. He loves this farming. Now these are just, you know what? So I have a question. You know how you have a herd of sheep, you have a pack of wolves? What's a group of birds called? A flock of birds, right? But with ducks, when the duck is in the land, it's a flock of ducks. When it's in the water, it's a paddle of ducks. I learned that recently, okay? So there's a group of ducks. They go in the water. Just watch this carefully, it's very interesting. And you see this one little duckling, that's not going in. And then the duckling makes noise, okay? And you'll see that entire group or flock of ducks, it went back for that one little duckling, okay? And I'll tell you why. You can see why now. When they chose to go by land, and the duckling had a broken leg. They all went back for the one duckling. Okay? This is my father and I'm very close to him. He's taught me all these life lessons. Okay? I am open for questions. I leave you with a few of my contacts, and thank you very much for listening to me.